Hi, my name is Akash Patel. I'm a consultant trauma and orthopedic surgeon, and I work in London. Today, I wanted to talk to you about hip osteoarthritis. So, the first question that I get asked is, what is osteoarthritis? So, osteoarthritis is a degenerative condition of the cartilage. So, that's where the cartilage around the joints wears away. There are two broad causes of this. One is genetic, which we don't really understand, and we're trying to get to the bottom of this. And the second cause of osteoarthritis is environmental. So, what we do with our hips, our knees, for example, if we get lots of injuries or instability, etc., around that the hip joint, then we're at higher risk of developing osteoarthritis. The other important thing that we have to consider, what are the symptoms of osteoarthritis of the hip? So the most common symptom is pain. So pain is usually around the hip joint itself. It's around in the groin area. It can be around the side of the hip. It can be around the buttock. And it's not uncommon for this pain to be referred. That means it moves down the thigh, down towards the knee. So sometimes we see patients presenting with knee pain, but actually it's coming from the hip osteoarthritis. It usually affects patients who are slightly older because as we progress with time, we wear out. The other symptoms of osteoarthritis, apart from pain, are things like stiffness, limping, limited general mobility. Because as we wear out, as the cartilage wears out, the whole joint becomes more stiff. So that's an important factor for us to consider. In terms of the diagnosis for hip osteoarthritis, history is very important. So we ask the patients where the problem is, where the pain is, because that gives us guidance of what the issue is, how badly is the pain affecting the patient. We talk about past medical history, function, what the patients can do. Is the pain constant? Does it come? Does it go? What previous treatments that they've had? What tablets that they're taking? Are there any painkillers? Have they tried physio? All of these things are key in the history. Second, we examine patients. So we take a look at the patients. We see how patients are walking. We can check things like their footwear, their gait or walking patterns. Then we look at the hip itself. We look for any leg length discrepancies. One leg might be shorter or longer than the other. We feel around the hip. We move the hip because we know one of the classic symptoms of hip osteoarthritis is stiffness. We check the blood vessels and nerves in the legs, and we always check the joint above and the joint below. So we examine the spine and we check the knee because these are all interconnected. After we've taken a history and examined the patient, then we undertake an x-ray. Okay, the x-ray is important because it shows us the ball and the socket, and it shows us the degree of wear and tear or the degree of osteoarthritis in the hip, which then gives us an indication of what the next potential step is. After we've undertaken that diagnosis and we've confirmed that this is hip osteoarthritis, we talk about treatment options. So with anything, there are non-operative treatments and there are operative treatments. So the non-operative treatments are very important to consider for hip osteoarthritis. First thing we say to patients is think about physio, because the physio helps with building range of motion, muscles, flexibility around the hip, and balance. And this contributes to improving symptoms and supporting that joint. The second thing is activity modification. So this means trying things that don't flare up your pain and essentially considering low impact activities and exercises, things like swimming, cycling, yoga, Pilates, walking, all really, really important. Third is painkillers, so simple things like paracetamol or anti-inflammatories if you can tolerate them. And then the fourth is lifestyle. So that just means eating properly, drinking properly, sleeping properly, watching your weight, because the heavier that we are, the more pressure, the more load the joints have to take on, and that can flare up the pain. Next step after that to consider are injections. So there are lots of different types of injections that we undertake. The most commonest one is a steroid and a local anesthetic. This helps to reduce any inflammation, and this can also help to reduce the pain. It has risk and benefit. So the benefit is improving symptoms, but the risks are things like bleeding, infection. They may not always work, and they only last limited amounts of time. Then the surgical option, which is one of the most commonest operations really that I undertake, are hip replacements, total hip replacements. So total hip replacements involve removing the worn out bits of the ball and the socket. So we remove the ball, we remove the socket, and we put in a brand new socket and a brand new ball. These are made up of different components. You can have cemented or uncemented hips. You can have metal, plastic, and ceramic as part of the components. For me, my practice is very bespoke, so I undertake hip replacements depending upon the patient and the patient's anatomy. I use both cemented and uncemented components, and I do use combinations of metals, plastics, and balls, different balls. So the other thing to consider is the approach. So everyone asks actually, what is the best approach? Which dissection? How do we dissect? Which way do we go? Do we go from the front, anterior approach, the side, or the back? And actually, if you look at the data, there's not a huge amount of difference in the outcomes for all of these approaches. And in my practice, I have undertaken all three approaches for hip replacements. And for me, my mainstay of treatment and approach is from the posterior, meaning the back of the hip. This is usually good. It's tried and tested. It gives us good access to the hip joint, allows us to see the socket in good detail. And globally, most surgeons undertake a posterior approach to the hip. Then we talk about the risks of hip replacements are bleeding, infection, swelling, stiffness, scars, damage to the structures such as blood vessels, nerves. These risks are small. You can have fractures, dislocations, leg length discrepancy, meaning one leg longer or shorter than the other, blood clots, anesthetic risks, and sometimes they can become loose. However, hip replacements are so good these days, we expect them to last anything from 20, 25, or even 30 years. And the benefit of hip replacements is improving the symptoms. Now, not everyone has to have an operation. So the thing I always emphasize to patients is always try the non-operative treatments first. Always try the physio, activity modification, weight loss, lifestyle changes, painkillers. And then if you're still struggling with the pain around the hip, then it's absolutely reasonable to go forward and consider total hip replacement surgery. In terms of what it involves, so after we've diagnosed, we've undertaken a history examination, x-rays, and plan to go forward with an operation. Patients usually have a pre-assessment, so the anesthetic team will check the patients to make sure they're fit enough for surgery. Patient comes into the hospital, we undertake the procedure, and the patient's up and about walking either the same day or the day after. And patients are usually home in approximately 24, 48 hours. After the surgery, patient has an x-ray and a blood test as standard routine practice, and then I will see the patient in 2 weeks after the surgery to ensure the wound is healing. The recovery period, the first 6 to 12 weeks, the patient has some soreness, but it gets better, and it can take up to 1 year for a full recovery. But in summary, we've talked about osteoarthritis of the hip. We've talked about what it is. We've talked about the importance of diagnosis in terms of the history, examination, investigations, and then the various treatment options.